Hello and welcome to another acute medicine tutorial. The topic today is acute hepatology, which is a personal interest of mine, and this morning we're going to focus on liver failure. Some of the slides are taken from the European Association for the Study of Liver, and the references are on there. I'd also like to credit Dr. Jennifer Ryan, a consultant hepatologist at the Royal Free Hospital, who's also supplied some of the information. What are we going to talk about today? We're going to talk about the epidemiology of acute liver failure, trends in the United Kingdom, definition of acute liver failure, clinical course of acute liver failure, the history and assessment, manifestations, and your approach and investigations. So I'd like you to think about this case. So this is a 25-year-old male who attended the emergency department with metacarpal fractures following an altercation while intoxicated. He was put in a cast and discharged. 5 days later, he attends the emergency department with confusion. Assessment showed the confusion, blood pressure of 90/60, heart rate of 120, respiratory rate of 30. His bloods showed a ALT of 25,000, pH of 7.24, lactate of 15, INR of 9, and a creatinine of 450 micromoles per litre. So hopefully you'll be thinking that this is a presentation of acute liver failure, and you should already be thinking about how this has happened, and hopefully you'll be thinking about this is probably an inadvertent paracetamol overdose due to the fractures. So when we look at the epidemiology of acute liver failure, you can see, following on from that case, that the paracetamol toxicity and acute liver failure accounts for the vast majority of cases around the world, and indeed in the United States it accounts for over 50% of their acute liver failure presentations. Now you can see that not far behind you have indeterminate, and the third you also have drug-induced liver injury, and there is a different presentation for that on Moodle which you can read. Next is you've got the hepatitis viruses, at least particularly hepatitis B, although that does have a vaccine, but I'll show you still the prevalence of hepatitis B across the world on the next slides. Autoimmunity and ischemic liver injury. Then you have the more rarer things such as fatty liver pregnancy leading to acute liver failure, Budd-Chiari syndrome, which is basically a paradoxical thrombosis in the portal vein, ischemia, and then you've got hepatitis A, which is relatively common in some parts of the country, although usually clears itself spontaneously. And this is data from the Lancet. So, acute liver failure is a rare but life-threatening condition, rapid progression, which is why I'm aware that you do gastroenterology in Module B, but I thought actually this is a rare but very important presentation to acute medicine, which must be managed urgently. There are less than 10 cases per million population, and data from the Cleveland Clinic suggests that in the United States it's about 2,000 cases per year. It often affects younger people. Now what's important is that there is a 40% mortality rate. It is more common in developing countries because of the higher prevalence of viral hepatitis. So here is a geographic map here of the world, as you can see, and what I'm trying to get you to appreciate here is the sort of the worldwide spread of a virus, for example, like hepatitis B. You can see that it's prevalent, highly prevalent in Africa and the Far East, Asia, South America, and so on. And so actually, it's these sort of causes of acute liver failure are worldwide. Now, obviously, in Eastern Europe and the United Kingdom, of course, we have a hepatitis B vaccination program for men who have sex with men and healthcare workers as well. So the more developed countries will tend to have vaccination programs, and indeed you would have had to have your hepatitis B vaccinations for working in medicine. So this is local data. This is data from the UCL Research Liver Group. You can see that basically 80% of those with acute failure will die without a transplant, and we'll talk about transplantation later on in the presentation. Acute liver failure is the second most common cause of death in middle-aged UK men, and that can be, for example, for cirrhosis due to alcohol and also non-alcoholic fatty liver disease or NAFLD. It's the fifth leading cause of death in the UK for under 65s, and only 2 in 3 people on the transplant list will get a new liver on time, which means 1 in 3 will die. 650 million number of people worldwide with liver disease, according to World Health Organization, and £450 million is the burden of NHS the cost of liver disease to the NHS. So this is a rather dramatic graphic, but I think you can appreciate the point here. So this is data from the 1970s coming up to 2006, and you can see the rather striking difference between the red and the yellow line, and the red line represents all cause or change in standard death ratio since the 1970s, how much liver disease continues to be a burdening problem in the United Kingdom, whereas the yellow line represents mortality changes in chest disease. So you can see that nearly all of the other conditions are slowly declining, whereas death due to or change in death rates due to liver disease is rapidly rising. This slide here demonstrates age standardized alcohol-specific death rates per 100,000 population. This is UK data from 2001 to 2017. You can see that in England we have a particular drinking problem, it seems, in the early 2000s. That is steadily improved in the early part of the 2000s, but again is leveling off. Interestingly, in Northern Ireland, Scotland and Wales, it looks like, although fairly flat, all-cause mortality due to alcohol is starting to rise. So what's important to realise is that alcohol and alcohol-specific death can occur at any age. You'll notice that the peak essentially is in the middle age, so it's a good bell curve for population. But you can see that on the left of the curve, it starts at age 30, peaks at around 55 to 60, but does also include the extremes of age at 85 and over. So what is acute liver failure? So acute liver failure is a rare syndrome defined by a rapid decline in hepatic function characterized by jaundice, coagulopathy and hepatic encephalopathy in patients with no evidence of prior liver disease. The interval from the onset of jaundice to the development encephalopathy occurs within 24 to 26 weeks and may further classify acute liver failure into categories such as hyperacute, acute and subacute, and we'll come on to that shortly. So let's have a look at the definition and clinical course of acute liver failure. So you will have a severe acute liver injury, and the sort of classic or syndrome, if you like, is that there is no underlying chronic liver disease beforehand, but you will have a presentation of liver damage with 2 to 3 times the upper limit of normal of the transaminases, as there certainly was in this case. And you'll have impaired liver function with jaundice and coagulopathy, with usually an INR of greater than 1.5 or a PT, or prothrombin time prolongation. Now, then you will have the development up to about 12 weeks post jaundice, depending on the subclassification, which we'll come on to again in a moment. Patients will then begin to develop hepatic encephalopathy, which is important for the diagnosis of acute liver failure. And as I've talked about in the presentation on managing the unconscious patient, encephalopathy can be very subtle, and so it does take a skilled clinician and a really good thorough search for hepatic encephalopathy if you're worried about it. So you have to do quite intensive screening to diagnose hepatic encephalopathy. It certainly becomes much more apparent in the later stages. So let's have a look at some of the development of jaundice. So again, when you're thinking about the possible causes, you'll see, for example, so let's talk about paracetamol, which is the most common, particularly in the United Kingdom. You'll notice that often the development of jaundice to hepatic encephalopathy is very hyperacute, and that's within a week. And actually, in my experience, albeit limited, of acute liver failure, in terms of severe liver failure, the cases that I have seen, they've all presented within a week when they've had a paracetamol overdose. So you'll also notice that acute hepatitis A, which you tend to see more in the Far East and Asia and the Middle East, you will also get hyperacute jaundice, but in hepatitis A, it usually does settle. Then in hepatitis B, it can be 1 to 4 weeks. And then in subacute, so non-paracetamol drug-induced, so DILI as this otherwise known as, it can be much more longer, up to about 12 to 28 weeks. And then after 28 weeks, it becomes chronic liver disease. At the extreme end, for example, in hyperacute liver failure, you'll get very severe coagulopathy, whereas in subacute, it's much more insidious. But in subacute, you'll have much more severe jaundice than you will in hyperacute. And also hepatitis B is kind of half and half, if you like. It has moderate chance of spontaneous recovery. There is a very significant degree of intracranial hypertension in hyperacute liver failure, which means that patients will often get intubated very early, and we care for them as if they've got a head injury. And there are certain ways that we will do that in intensive care. So let's look at some of the principal etiologies of acute liver failure. So the most common one, for example, is drugs on the left. So the most common one being paracetamol. As I say, there is a tutorial on drug reactions on Moodle for you, but you can see from this list how easy it would be for a lot of these drugs to cause drug-induced liver injury and acute liver failure, and these are things that we prescribe all the time. So chemotherapy, statins, non-steroidals, phenytoin, carbamazepine, ecstasy, and even something like flucloxacillin, which you prescribe routinely for cellulitis. Then you have viral hepatitis, so B, A, and E. You also may get CMV, herpes simplex virus, or varicella zoster, or dengue. Also, of course, you can get hepatitis C, or that tends to cause chronic liver failure rather than acute, as in the vast majority of cases, hepatitis C is cleared spontaneously within about 3 months. Patients can be reinfected with hepatitis C, and again, they may clear it. So hepatitis C is more in the realms of chronic liver disease management. Then you have things like toxins such as phosphorus and amanitophiloides. You have the more rarer genetic conditions such as Wilson's disease, autoimmune lymphoma, malignancy, and lymphohistiocytosis. You may have vascular malformations such as Budd-Chiari syndrome or hypoxic hepatitis, and that's usually from heart failure or severe septic shock, for example. If your patient is pregnant, you can have acute liver failure from preeclamptic liver rupture, hemolysis, elevated liver enzymes and platelets, and also fatty liver of pregnancy. So let's focus on what you would do to take a history and assess a patient who you think has acute liver injury or acute liver failure. So as I said in a few tutorials, it's about being a good detective. You want to search for an etiology. Has the patient used any medication, particularly paracetamol? Again, you want to ask about timing, amount, possibly. Have they taken multiple medications with paracetamol in, for example, over a period of the past 6 months? Any history of substance abuse, and again, don't just think the classical drugs, also think over-the-counters, herbal supplements, diet supplements, anabolic steroids, and also their method or route of administration. Has the patient ever experienced depression or made a suicide attempt? So could this be acute liver failure secondary to paracetamol overdose or an attempt at suicide? any gastroenterological effects after eating mushrooms. You then want to try and identify the conditions that could cause acute liver failure. So, is the patient pregnant? Has the patient travelled in hepatitis B or HEV endemic areas? And obviously, you've seen the prevalence of HBV in the world in an earlier slide. Is the patient receiving immunosuppressive therapy or chemo? And again, that's quite important because if they are immunosuppressed, they are more likely to get viral hepatitis due to varicella zoster virus or Epstein-Barr or CMV. Is there any history of autoimmune disease? So think about rashes, sore joints, myalgia, arthralgia, and so on. So then if your patient is in a critical condition, we then want to think whether an emergency liver transplant is feasible. So is there any history of chronic liver disease? Are they currently using or dependent on alcohol or drugs now? That doesn't necessarily mean that a patient can't have a transplant, contrary to popular belief. What it does mean, though, is that the patient would have to be, where possible, psychiatrically assessed and have a very strong support network and rehab potential so that the liver isn't destroyed afterwards. Do they have a recent history of cancer where they would need specialist input to decide whether transplant would be feasible, or whether they've got any severe congestive heart disease or respiratory comorbidity? And again, that's important because you'll get a change in blood flow, of course, with a new liver, causing shunting and massive pressure effects on the heart and lungs. So just to recap where we've got to, so you've got acute on chronic liver failure. You can have an acute insult, and the list is on there. Also with chronic injury, which can then cause chronic liver disease, cirrhosis, asymptomatic, or be compensated or have no prior decompensation. So you can go from an acute insult to chronic injury without necessarily having fulminant hepatitis. You can, of course, deliver liver failure, and the question is whether that's reversible. Now, you can have acute on chronic liver failure, which is treatable, and certainly encephalopathy can be reversed with proactive treatment. So what are some of the clinical manifestations of acute liver failure? As you can see, it's multi-system and multi-organ. So obviously with the brain, you can have hepatic encephalopathy, cerebral edema, intracranial hypertension, seizures. The heart can develop subclinical myocardial injury, hepatocardiac syndrome. You can get pancreatitis, acute lung injury, bone marrow suppression, anemia, thrombocytopenia, systemic inflammatory response syndrome, loss of metabolic function, hypoglycemia, hepatorenal syndrome, AKI, and electrolyte abnormalities. So you can see that as all the organs are important, you can see that damage to liver can have catastrophic domino type effect around the other organs. So what's your initial approach to patients like this? A, B, C, D, E. You want to probably get these patients intubated early as they will lack to maintain their airway, high risk of aspiration. You want to give them vitamin K, so potentially these patients are often vitamin K deficient. And so we give vitamin K 10 milligrams IV for 3 days. IV fluids, now occasionally if there is renal involvement, we'll give them human albumin solution as well. You want to give broad spectrum IV antibiotics and antifungals. Similarly to when dealing with a patient with cirrhosis, this is one of the key things, is that these patients are very, very vulnerable to atypical bacterial and fungal infection. These patients often will need nutritional support via NG feeding and referral to hepatology or specialist liver centre such as King's College in London or the Royal Free. The hepatology team will consider liver transplant, and of course you want to consider the cause, and it's a general principle that you would administer N-acetylcysteine or Parvlex in case it's a likely paracetamol overdose. So you want to assess the disease severity by doing a coagulation screen, liver function test. You want to catheterize your patient, do renal function tests, arterial blood gases, lactate levels, and an ammonia level. And ammonia is not necessarily diagnostic of hepatic encephalopathy, and the level doesn't necessarily correlate with the degree of clinical encephalopathy, but certainly can be useful if you want to confirm your diagnosis of encephalopathy, or you have a patient who has reduced level of consciousness with query cause. A elevated ammonia will point to some form of encephalopathy. You want to do urine and paracetamol salicylate levels, urine toxicology, viral screen. So you'd want to do hepatitis B surface antigen, anti-hepatitis B core IgM, which would give you an idea about whether patients actually had hepatitis B in the past and has any antibodies. You'd also particularly want to do hepatitis D, HAV, HEV, and so on. You'd also want to do an HIV screen as well, especially if you were considering transplanting. You could also do autoimmune markers as well. Other tests include things like lipase, amylase, so that's looking for pancreatitis, lactate dehydrogenase, split bilirubins, creatine kinase, and obviously you can see on the right hand side you've got your list of autoimmune markers, so anti-nuclear antibody, anti-smooth muscle antibody, ANCAs, HLA typing, and so on. So what is the general support for and management of these patients outside the ICU? So you want to make sure that you screen them thoroughly for sepsis, so culture, blood, urine, respiratory, organise a chest x-ray, ECG, liver echocardiography. So you can do an ultrasound. What that means is you can do an ultrasound of the liver with Doppler flow studies, and that's looking for things like portal vein thrombosis, any sign of ischemic liver injury, ascites, and so on. ECG. You then of course want to monitor these patients very carefully. You can with your standard monitoring and clinical neurological examination regularly. So you want to give them glucose infusions. These patients who have fulminant liver failure can become rapidly hypoglycemic, so you need to give them 10 to 20% glucose infusions. You'd give them omeprazole or ranitidine, and that's to prevent stress ulcers. Try and restrict clotting factors, as paradoxically I've put in a central line before with an INR of 9 and had no bleeding whatsoever. Remember that although the blood isn't clotting properly, the clotting factors don't necessarily work very well, so you don't necessarily get the bleeding that you might expect. You'd always want to give NACs, especially if you have acute liver failure of unknown cause, antibiotics, antifungals, and you want to make sure that you check and correct any electrolytes, particularly sodium, magnesium, phosphate, and potassium. Where possible, you want to avoid sedatives, but those who have gross encephalopathy, then their airway will be at risk and they will need intubation. You want to be careful about any drugs that you prescribe, so be cautious of things like morphine, which can be hepatotoxic, and nephrotoxic drugs. And you want to avoid raising the intracranial pressure. So in that case, you'd want your patients quite well sedated and laid at about 30 degrees with their head up, and usually potentially paralyzed if necessary, because of the risk of cerebral edema. So what is the criteria for referral to a liver specialist centre? And this is just a few examples here. So for paracetamol and hyperacute, so that's liver failure within a week, arterial pH less than 7.3 or low bicarbonate, so acidosis, coagulopathy, acute kidney injury, low glucose, altered level of consciousness, and elevated lactate. Then on non-paracetamol, again, you have acidosis, coagulopathy, renal injury, elevated bilirubin, and shrinking liver size. So you don't need to pay particular attention to all of these things, but you can see some of the things that have to be considered, particularly in and out of intensive care. So often these patients are volume deplete and they'll need crystalloid volume resuscitation. Again, there's a tutorial on IV fluids on the YouTube channel. You may have to give them vasopressors. Again, these are drugs that squeeze the blood vessels, and we use noradrenaline in the case of acute liver failure. So acute liver failure, remember, is frequently associated with electrolyte and metabolic imbalance, particularly hypoglycemia and hyponatremia in severe cases. Patients can also develop acidosis. You can have alterations in serum phosphates, magnesium, ionized calcium, and so on. So basically, you have to make sure that these patients will often get a central line put in, potentially have renal replacement therapy if the acidosis is very severe. So what are the indications for liver transplant? So you can see all of here. They're basically classified into the acute liver failure group, such as paracetamol overdose, cirrhosis from chronic liver disease, so chronic viral hepatitis, alcoholic liver disease, and so on. Metabolic disorders, malignancies, hepatocellular carcinoma, and other miscellaneous things like polycystic liver, and so on. So you can see that we prescribe or plan for transplant in a large number of conditions, but again, due to the availability of livers themselves, unfortunately, these patients don't often receive their transplant. So what is the impact of liver transplantation? Well, I mean, it's one of the most significant developments in the treatment of acute liver failure in 40 years. And certainly we're a transplant centre at the Royal Free, and now 1 year survival following emergency liver transplant for acute liver failure is now around 80%. But of course, that does depend on the right selection. So accurate prediction of survival without transplant, consideration of the survival potential. So again, this comes to, for example, those who have issues with recreational drugs or alcohol, they're likely to be recidivists. Again, you don't particularly want to transplant someone a liver who potentially will have problems with maintaining their immunosuppression regime and so on, and attending follow-up. And then, of course, it's consideration about whether the transplant patient is too sick to receive a liver. So final slide, I've put up some resources for you here. So these resources are from the British Liver Trust. There's the British Society of Gastroenterology. There's a bit more broad detail on the NHS website. And there's also quite a good summary on the Royal College of Emergency Medicine learning website. So rcemlearning.co.uk. So I hope you enjoyed this tutorial. I think my colleagues at Whittington are planning to do more acute hepatology for you. There's also a tutorial on functional gastroenterology disorders. As always, you can email me. I think you all know my email address by now, and you can get in contact if there's anything particularly that you'd like to comment on or have any questions. We've just opened an acute medicine Q&A on Moodle. Take care, everybody, and I'll see you soon.